Moving along with our MSK curriculum, we're going to focus on the distal upper extremity and identify some of the most common findings in a primary care or sports medicine clinic for elbow and wrist pain. In this lesson, we'll focus on a basic intro to the anatomy of each of these locations and take a look at the most common clinical conditions seen. Like all things in MSK ultrasound, there's much more detail you can jump into, but we'll take a generalist's approach. Let's start things off with the elbow. A comprehensive view of the elbow involves 6 views of the anterior, medial, lateral, and posterior elbow. You should be able to identify the major bony landmarks, including the distal humerus with the lateral capitulum and medial trochlea, the radial head, and the olecranon of the ulna. It's also important to recognize the common origins of the forearm extensor and flexor groups, which are often involved in elbow pain. Starting with the anterior views, the patient should be sitting with the arm fully extended at the elbow. In the longitudinal view, seen here in the left image, the capitulum is seen with its characteristic dome-shaped hyperechoic bony cortex and posterior shadowing. Inferior to that, the radial head abuts the capitulum. A fat pad, usually hyperechoic and shaped like a small triangle or seagull, will sit over this connection with the joint space immediately deep to it. If the probe is rotated 90 degrees to the transverse view, the distal humerus is seen with a wavy, W-shaped articular surface. On both the longitudinal and transverse views, notice the arrows, which are pointing to the hypoechoic cartilage. Some learners will mistake this normal finding for a joint effusion. Effusions, by contrast, which I've included an image of down below, will characteristically displace the fat pad anteriorly, often rising above the level of the capitulum when viewed in the long axis. So here's an image of an elbow effusion with the asterisk marking the joint line, and the large anechoic collection of fluid is located under and anteriorly displaces the fat pad. So instead of having our normal seagull sign, which we can sort of see, it's got a little label over it up here, that fat pad is moved up. And I've flipped this so that it's the same orientation, but it's the same structure. The medial elbow is best examined with the patient partially flexing the elbow to about 30 to 60 degrees of flexion and externally rotating the arm out to the side. I like to think of this as sort of like a Shakespeare position, imagining an actor holding out their arm to give out a soliloquy, but that's just how I visualize it. The probe should be placed longitudinally over the medial epicondyle, which will be eminently visible as a bony landmark in the near field. The flexor group originates here before coursing distally. Medial epicondylitis, or golfer's elbow, results in pain over the medial epicondyle due to acute or repetitive strain on the common flexor origins due to valgus forces or forced wrist flexion. While classically associated with golfers, many sports and occupations can result in these types of injuries. And I've seen it in pitchers, quarterbacks, even in house cleaners and other occupations that are not sports related. Like many other types of tendinitis injuries we've seen in this module, the earliest signs of trauma seen using ultrasound are usually focal hypoechoic irregularities, which are thought to arise from microtrauma and edema of the affected tendons. Cases often progress to show small, or sometimes even pronounced, tears of the origins of these locations. Here, we have a couple images of patients diagnosed with medial epicondylitis. So in the top image, we can see the medial epicondyle on the left side of the screen. And then we have the common flexor tendon origin with micro little tears and hypoechoic defects seen pretty easily in this view longitudinally. And then similarly, in the lower image, we have a more subtle view, and that could just be because of our gain or because it's actually just a smaller injury. But once again, this common tendon origin originating on the medial epicondyle and then coursing distally with this little hypoechoic collection of fluid, most likely representing edema. The medial elbow also contains the cubital tunnel through which the ulnar nerve courses on its way to the medial forearm, wrist, and hand. The ulnar nerve is the second most commonly injured nerve of the upper extremity after the median nerve, which we'll talk about later. Similar to other MSK findings, nerve damage typically presents as thickening and hypoechogenicity of the involved structure. There are some studies out there that use cross-sectional areas and ratios to make the diagnosis, But for our purposes, I just want you to be able to identify thickening and hypoechoic findings relative to an unaffected side, along with a clinical history that suggests nerve involvement, as being supportive of the diagnosis. More advanced scanners may consider diagnostic nerve blocks of the ulnar nerve to solidify the diagnosis. The lateral elbow is best evaluated with the elbow flexed to a right angle and the forearm crossed across the body. The probe is placed in the horizontal position over the lateral epicondyle, and the radial head and lateral epicondyle of the humerus should be seen in the same plane. The common extensor origin arises from the lateral epicondyle. The probe can then be translated posteriorly to visualize the ulna deep to the radius. The radial nerve curses through the lateral elbow before crossing over the radius in the forearm to innervate the dorsal thumb, index finger, parts of the dorsal hand, and digits. Compression of the radial nerve can occur at the elbow or at its crossing point over the radius. So while radial nerve entrapment is a rare clinical entity, it is useful to know that investigation at both of these sites is important. A nerve block at the radial nerve can serve as a helpful diagnostic tool for differentiating median nerve versus radial nerve symptoms. Lateral epicondylitis is a common overuse injury seen in the primary care office. Colloquially known as tennis elbow, patients may present due to a variety of recreational or occupational hazards. Racket sports are common causes of overuse injury, as the grasping of rackets and forced wrist extension during volleys places stress on the extensor origins, which, like other muscle and tendon injuries, can lead to inflammation and or tears of these musculofibrous structures. Severe trauma can lead to tears of the lateral ulnar collateral ligament or the radial collateral ligament as well. Like in other conditions we've reviewed, hypoechoic irregularities are the most common findings due to tissue edema and or microtears of the structures in this area. The posterior elbow is best visualized with the patient flexing the elbow to 90 degrees and holding the elbow just off of the edge of a bed or table. Some patients may find that placing their hand flat on the table with the elbow lifted perpendicular up into the air provides more comfort for this exam. When looking at the olecranon bursa, having the patient extend the arm to reduce tension in this area allows for the best view of fluid collections anterior to the olecranon. In a normal view, the olecranon can be seen as a superficial, bony structure with hyperechoic signature and posterior acoustic shadowing, with the triceps tendon positioned superficially and the olecranon fossa with its fat pad deep in the olecranon fossa between the medial and lateral epicondyles on a transverse view. A common question when examining patients with elbow swelling is differentiating between elbow effusions, which involve the joint space, and olecranon bursitis, involving the superficial bursa that provides cushion to the elbow posteriorly. Using a high-frequency linear array probe, these can easily be distinguished from one another by identifying the location of the fluid pocket relative to the triceps tendon. Joint effusions will present as deep to the tendon and result in fat pad displacement superficially, as seen in the image here on the left, imaged in a transverse view. By contrast, the images on the right show fluid collections superficial to the triceps tendon. A common error is identifying the shaggy degenerative changes of the bone and chronic inflammation as an effusion. But this can be seen in conditions such as gout or other inflammatory arthroses and can be a clue as to the etiology of a patient's swelling and pain. On the left, we see the effusion with the fat pad displaced deep to the triceps tendon, which is up here. Then on the right, we see bursitis superficial to the triceps tendon, and we also see some shaggy degeneration here from bony changes of gouty arthropathy. As we move more distally to the wrist, ultrasound continues to be a supportive modality which we can use to investigate common injuries. So let's take a look at some of the common clinical conditions identified using POCUS for the wrist. As a reminder, a good knowledge of anatomy is critical for identifying the landmarks needed to diagnose wrist and hand conditions using ultrasound. As we all learned in medical school, the wrist is a complex joint made up of many small articulating bones, virtually all of which can be damaged in overuse, trauma, or inflammatory disease. Take a minute and see if you can remember all of the names of the bones of the wrist. Starting on the lateral and proximal wrist, we have the scaphoid, the lunate, the triquetrum, and the pisiform bones, which we don't see here. Then the trapezium, the trapezoid, the capitate, and the hamate bones in the next row. Similarly, the anatomy of the soft tissues, including tendon canals and compartments, is essential knowledge, especially for the most commonly injured compartments, which we'll look at in more detail shortly. The dorsal wrist provides windows for the extensor tendons and is best imaged with the patient holding the wrist in neutral flexion with the palm facing down. The probe can be placed in the transverse view over the proximal wrist by first identifying the radius and ulna. An important landmark is the bony prominence on the radius known as Lister's tubercle. This separates the second and third extensor tendon compartments and serves as an anchor point for the extensor retinaculum. Starting here, the probe can then be translated distally to image the extensor tendons as they course into the wrist and hand, and to serve as landmarks for the carpal bones, which could be fractured or dislocated in traumas. I know you've all been wondering when we get to another one of my professional illustrations, so I didn't want you to keep waiting any longer. So these series of sketches show how the extensor compartments appear as you translate your probe distally down the wrist. These are all taken in the transverse orientation. So here, the bony surfaces are represented by white lines, and the extensor compartments are color-coded, with the second extensor compartment in green on the right, and moving to the sixth extensor compartment in purple on the far left. The first extensor compartment lies laterally along the anatomical snuff box and is usually not seen unless you move the probe specifically overlying this area, which we'll go over on the next slide. But note that as you translate distally, the radius and ulna will completely disappear from view, and the smaller carpal bones, such as the scaphoid, lunate, and the ligamentous complexes, such as the TFCC and the scapholunate ligament, will become visible. Let's take a few slides to review some of the most common structures of concern to the primary care physician in the dorsal wrist. Starting off with the first extensor compartment, we can examine the snuff box by placing the wrist in a neutral degree of flexion with the thumb oriented upwards towards the ceiling. Some clinicians image with the thumbs up position with the thumb extended, but I prefer to keep the thumb neutral as this provides a better degree of contact between the probe and the skin. Your landmarks for this view are to visualize the distal radius as it ends, and occasionally you can see the bony echogenic reflection of the scaphoid deep in the snuff box. The first compartment tendons, namely those of the extensor pollicis brevis and the abductor pollicis longus, course through the anatomic snuff box and are commonly injured in patients who repetitively grasp objects or forcefully extend the thumb. Commonly, new mothers will experience this condition due to grasping their babies, but I also commonly diagnose de Quervain's tendinosynovitis in construction workers, hobbyists, people who type on keyboards or play musical instruments like the piano. While it's easiest to see these tendons in the long axis, diagnosing de Quervain's is easier in the short axis, and I'll explain that on the next slide. So as you might have gathered, injury of the first extensor compartment results in the ultrasound findings similar to other MSK injuries, namely showing hypoechoic disruptions of the normally linear and highly anisotropic tendons. The first extensor compartment also has a prominent synovial sheath, and so fluid in the sheath is a common finding that results in hypoechoic or anechoic fluid peripherally surrounding the extensors. These findings can also be present in other tendinosynovitis of the wrist extensors, and while the first compartment is the most commonly injured, the second and the sixth compartment are the most frequent. I'm going to put up this slide just again to remind you that you're using your landmarks to examine these different structures, and that all of those different findings that we just take a look at can also be present in any of these other extensor compartments as well. And so you're just going to have to look at your anatomy and sort of know where your findings are to be able to identify which compartment is involved and direct any therapy that you might prescribe for your patients. As we move to the volar wrist, the patient should be positioned with their palm up, once again with the wrist in neutral flexion, and the probe should be placed transverse over the carpal tunnel. Be careful to avoid providing too much pressure when you're placing the probe in this area, because you can cause some difficulty being able to identify the structures from one another if you apply too much pressure. So I will often use a water bath or a gel offset pad to be able to better see these superficial structures. Our landmarks for the volar wrist are our flexor tendons, which are all sort of mixed up together here inside the carpal tunnel. And of course, the big player is our median nerve. To identify the median nerve, there's a couple of different approaches that you can take. One of the ones that I use most commonly is knowing that the median nerve will course deep in the forearm up until about 5 to 8 centimeters above the flexor retinaculum in the wrist. And so you can sort of translate your probe proximally and identify structures. And if that structure that you have in question is starting to dive deep as you course more proximally up the arm, that's a good idea that that's probably your median nerve. You may also notice that it has a honeycomb or fascicular appearance, although this may be less noticeable in the carpal tunnel. And then most commonly, you can use anisotropy. And remember that nerves will show anisotropy, and the median nerve is certainly no exception to that, but it will have less anisotropy than the surrounding tendons. And so as you sort of fan your probe through the carpal tunnel, the median nerve will remain more apparent and change less in its ecotexture than the surrounding tendons that are involved. So you can sort of isolate the median nerve still being present on the screen as you fan through and subject those tendons to high degrees of anisotropy. So for example, if we have these appearing structures that all sort of look the same here, we can tilt our probe and fan through, and what we'll notice is that some will fade, or all of them will fade, but some will fade more than the others, and the one that's fading less is our median nerve. Carpal tunnel syndrome results via compression of the median nerve within the carpal tunnel, and findings include seeing an hourglass-shaped median nerve with swelling that is proximal to the compression, then tapering through the canal, and then once again swelling as you move more distally. There's a few different ratios that you can measure of the size of the median nerve that can help give you a radiologic cutoff for diagnosis, but there's some debate about what those correct cutoffs are. And because this is a symptom that presents very classically and clinically with a reproducible pattern of symptoms, this is not something that I routinely do in my clinic. However, if you've got patients that have findings that are atypical or equivocal, or they failed conservative therapy for carpal tunnel syndrome, you might want to consider using some of these measurement-based diagnosis cutoffs to help solidify your diagnosis. Or unfortunately, some of these patients will need to be sent off for EMG or specialist consultation. And that's our examination of ultrasound for the elbow and wrist. Once again, this is a superficial look at the different pathologies that sometimes arise, but most commonly, these are the things that are going to be popping up on your clinic schedule and certainly on your board exams from a generalist point of view. We'll extend our conversation into the lower extremity in our next lesson.